What's up, everyone? My name's Hunter. I am a first-year emergency medicine resident. We're about 8 months through my very first year of emergency medicine residency, and we are reacting to the PITT. Here is Season 2, Episode 8.
Next time, maybe inform the department chair before the shit hits the fan.
I was on my way to tell you.
Make sure you get everything you need.
Okay, let's do this. All right, everybody, circle up.
What the fuck?
We may have had a cyber attack.
No, we shut down to prevent a cyber attack.
Okay, everybody settle down, listen up. As you can see, we're doing a little redecorating in the central work area. Our hospital computers are at risk for a cyber attack, so we are going old school, analog. So, first order of business, we need to replicate the electronic patient boards on these dry erase boards, so please somebody tell me they got a photo of the boards. For patient privacy, all chief complaints will be abbreviated, so HA for headache, AP for abdominal pain, and so forth.
Central 10, Jackson Davis, new onset psychosis, Javade, psych admission.
Greek letter Psy for psych?
Nurses need to convert to a zone defense, north, central, south, trauma.
Where's Dana?
In with a sexual assault case. She can't leave until the exam is finished.
Yeah, it could be a while.
Princess has charge nurse experience.
Not really.
Great idea. Princess it is. You can make the nursing assignment.
For those that haven't been following along with this season, at the end of the last episode, they brought up that the other hospital in the area had been on divert because of a cyber attack that took down all of their systems, so all of the patients were coming here to their hospital, and now they have shut down their electronic medical record in order to prevent a cyber attack. And in doing so, they have had to go analog with all of their systems, from the list of patients that they're treating to all of their orders, their notes. Everything is going to be handwritten from here on out. I have never had to experience this. While I was rotating during my 4th year of medical school last year, there was a cyber attack kind of nationwide that caused a lot of problems. I was actually on shift when it happened, but for some reason it didn't affect the hospital that I was at, so we didn't run into this. But I can imagine the stress that everyone is under in these circumstances, because I'm sure most of them, as is the case with me and my peers, we've not had to have experience with analog services in the emergency department, or really with medicine at all. So this would be a very stressful situation on top of what is already a stressful environment in the emergency department.
How many hours a day are you on your laptop?
At least 8 hours. I work from home.
And are you at a desk all day?
No. I will either sit on the sofa, or sometimes I'll be in bed, kind of sitting up with the computer on my lap, that kind of thing.
So you're always looking down at the screen?
Yeah?
Okay, I'm going to check the muscles in your neck.
Oh, ow, that hurts.
All right, well, I think we can help.
For the history, circle the positives like vomiting and diarrhea, backslash the negatives such as recent travel, sick contacts, fever. For physical exam, check mark normals on the left and circle any abnormal findings on the right. Questions?
Is your generative AI program still going to be working?
Not for a while. And ditch your SpectraLink phones. There's your voice over internet.
PTMC emergency. Go ahead, Medicommand.
That is how we will hear about incoming runs.
Thanks. 2 minutes out with abdominal pain and fever.
Okay, has everybody got that so far?
How do we write orders?
Physician order form in triplicate, labs, x-rays, IV fluid, medication.
Will the lab still be able to run blood tests? And
Yes.
Are the CT scanners still working?
Yes, but the results will come back on paper from the radiologist.
This is the dark ages.
So if you have orders with labs or x-rays, they go into the clerk file here. They will sign them off. They will add a downtime slip on them, make sure they go to the correct department.
I'm sorry, who are the clerks?
You're looking at
Larry and Antoine are filling in until more help arrives.
I wonder if this is going to cause problems due to poor handwriting when it comes to making orders and writing requests and things. This is kind of why doctors get a bad rap for having bad handwriting, is because everything used to have to be done by hand, and when you have so many patients to see, you end up scribbling very quickly the least amount of information that you can. So they were talking about different physical exam findings, just doing a plus versus striking things out for a negative. It's a lot of shorthand in medicine, which we have not had to do for quite some time. And so I can imagine that when they revert to this type of system, there might be some errors that are made due to not being able to read someone's handwriting.
Here is your antacid. Cheers. And I marked the trigger point that is bringing out your headache, and a shot of local anesthetic in that area could really help.
Yeah, let's do it.
Great. You are going to feel a little pinprick and some burning.
Oh, ow, ow.
Whenever injecting anything, but especially a local anesthetic, you should be aspirating on the syringe or pulling back a little bit to make sure that you're not in the blood vessel. In this case, she's doing a trigger point injection where she's trying to inject a little local anesthetic into a part of the muscle that is causing some tension, and then that radiating up into the head, causing a tension headache. But if she injects this into a blood vessel and into systemic circulation, you can become very toxic very quickly, resulting in seizures, cardiac arrhythmias, and death. I'd like to see her aspirate before she injects this.
It's been on and off for about a week.
And where do you feel it?
All over. It started on the left, and now there's some on the right.
How about that fever?
Since last night, I was burning up, and then I had chills pretty bad.
Can't find a vein here.
We'll try for midline.
Let us know if this hurts. Sorry.
And on this side?
Yeah.
Sorry.
Guarding with no rigidity for pain 100 of fent-IM. Plan Dr. Whitaker.
Blood cultures, lactate, Zosyn. We're gonna need a CT to figure out what's going on. Yo, it's not gonna work.
Yep, right neatly. Penman chip counts.
My word, for the scan, we're gonna have to lay you flat on your back. Can you do that?
I could 10 years ago, but now it's too hard to breathe. If we can't lay you flat, then we're gonna have to put a tube in your windpipe to help you breathe. Are you okay with that?
Intubation with rapid sequence induction?
No, we can't lay him down.
No, the tube will go in your nose while you're awake, sir. Well,
Right.
Does it hurt? You'll be numbed up completely. You won't feel any discomfort. Do you happen to know your weight? A little over 400.
Well, when was the last time you checked?
It's been a while. Is it possible that you might be over 450? Possibly. Perla, let's call for the Hoyer. So we're gonna place the tube and get you ready for the scan. Is this something serious?
It's hard to tell without a CT.
You could just need antibiotics, or you could require an operation.
If surgery is necessary, then your weight could make things a little bit more complicated. I know, I'm sorry. Not to worry, we're gonna take very good care of you. Team.
Pain medicine.
Let's try for a midline. So then with ultrasound guidance.
Can ultrasound check for an appy?
He's a little too large for ultrasound. Plus, our CT can only handle 450 pounds.
And so if he's over that, we send him to the zoo?
He's right there.
I heard that there's a large animal CT at the zoo.
Presby CT can handle 650.
Yeah, if Presby's still up and running.
What?
That's not a jinx. It's.
Have any of you ever done an awake nasal tracheal? Okay. Perla, can you also ask Dr. Al-Shimi to come in? I'm gonna need an assist.
Yep, you got it.
Sorry, signed.
This case highlights something that we run into quite often, not always due to a patient's size, but often due to a patient's respiratory status. It's very important in many cases for us to get imaging, whether it's of the chest, the belly, the head even. And if somebody can't lay flat to go into the CT scanner, then we have lots of problems. And oftentimes the reason that people can't lay flat is because of their ability to breathe. And so sometimes we have to intubate people simply to get imaging. And they're talking about doing a nasotracheal intubation on this patient with the patient awake because in order to intubate patients, we often have to lay them down. And in this patient's case, if they lay him down before they're ready to put the tube into the trachea, he could desat and arrest before they're able to do so. And so doing an awake intubation where they numb up the nasal airways, the oropharynx, and give the patient some medications to help with anxiety, they can take a flexible scope to go through the nose into the throat and then see the cords and pass a tube over that scope through the cords, get him intubated, and then put him to sleep and on the ventilator. I actually had a case that was similar to this, not exactly, but I got to use the flexible scope in one of my recent patient encounters. So if you enjoy seeing some of this style of content and want to learn more about how things are as an actual emergency medicine resident, you should check out all the vlogs that I have on my channel.
The hospital Wi-Fi isn't working.
Oh, it'll be down for a while. Sorry. Mom broke her leg, Grandpa.
We heard.
How are you, honey?
You've got this, kiddo.
Yeah.
How long will she stay in the ER?
Oh, until a bed opens up upstairs.
We get this question. This is maybe the most common question that we get in the emergency department when we have the discussion that we are going to be admitting the patient for further evaluation and management. The first question is, how long until I get a bed? Or how long will I be staying here? And we never know the answer. I mean, there are some people that know the answer, but as the docs in the emergency department, we have no idea. We know sometimes that there are beds available upstairs, and we know sometimes that there aren't any available. And when those beds will become available, who will get those beds, that is completely out of our hands, and we really have no idea. So I like to say that you will get a bed as soon as one becomes available, but when that is, I have no idea. And it sucks. I like to give answers to patients, but that is one that we just don't have.
Listen up. This is oxymetazoline, so open up the passage.
I'm going to squirt some numbing gel in your nose. If it drips back in your throat, that's okay.
Here, in case you need it.
Do you exercise?
Moving from the bedroom to the kitchen. No, I'd walk more, but I'd need a bench to rest on every block.
What about water aerobics?
Let's focus on helping Mr. Knox.
Agreed.
Took me 25 years to get this way. Car crash, burn unit, 4 leg surgeries over 10 years. Laid me up so much I lost my job.
I need to numb the back of your tongue. This is gonna taste pretty bad. Now that we've numbed up the back of your tongue, we can anesthetize a bit deeper. Just gonna go over your tongue and numb your vocal cords.
I think they actually showed that very well. Whenever we do a awake intubation or even just a direct laryngoscopy where we're just taking a look at the cords, it's a very uncomfortable situation for the patient. I mean, if you think about shoving anything in the back of your throat, you're going to gag, and we want to prevent that from happening because if the person vomits, then they have a risk of aspirating that vomit into their lungs and causing even more problems. And in this case, they showed perfectly. We use Afrin or oxymetazoline spray in the nose to open up the airways as much as we can, and then we spray a lidocaine or other topical anesthetic. One that is sometimes used in some departments is actually cocaine. It's a great anesthetic and vasoconstrictor, so it both opens up the airways and numbs them. So there is a medical use for cocaine, and that is what it was initially developed for. And then after the nasal airways are numbed up, we numb up the base of the tongue with a very viscous lidocaine or a gel, and that kind of melts and drips into the throat so that the throat, base of the tongue, kind of posterior portion of the mouth are numbed up. And then we're able to take what was that little syringe and what is called an atomizer with more lidocaine that can then spritz and mist lidocaine into the rest of the oropharynx so that they're completely numb when we try to pass this scope and take a look at the vocal cords and intubate. And they did all of that in a very quick succession, but very, very well done in that scene.
Brooke, you've met Dr. King. This is Dr. Al-Hashimi.
Nice to meet you.
And her wife, Wendy.
Hello.
Hello.
Okay if we discuss your symptoms?
As long as I can correct you if you get anything wrong. Trust me, she will.
1 hour of sudden painless vision loss in the left eye, no history of hypercoagulable state or vascular disease. Could you look straight ahead, please?
Could be a central retinal artery occlusion.
In English, please?
A little blood clot can block the artery at the back of the eye and decrease your vision.
Sometimes it's called an eye stroke.
Stroke? Like she could be paralyzed?
No, this would be limited to the eye.
Is it permanent?
First, we have to make the diagnosis. Retinal exam?
Hard to get a good look.
We need the FOP.
The what?
I'm not sure what an FLP is, fundoscopic something. Typically, if we have a patient with an eye complaint, we get out what is called the slit lamp, which is a very large contraption, something that you might see in an optometrist or ophthalmologist office, but we do have them in the emergency department, and it allows us to take a look at the eye very close up in a magnified fashion, but then we can also see through the pupil into the posterior part of the eye and see the retina. And they mentioned a central retinal artery occlusion, but there are a bunch of different diagnoses that can be causing this vision loss. We kind of take a look at vision loss in two categories. There's painless and painful. We look at whether there is a red eye versus not. And then there are a bunch of different diagnoses that I won't get into right now. But with the slit lamp, we're able to take a look at the anterior chamber of the eye, the posterior chamber of the eye, and get a better idea of what might be causing the blindness. And then most times we are making an urgent or emergent consult call to an ophthalmologist to help fix whatever the problem is. I'm very curious to see what the FLP is, though. I haven't heard that one. One other interesting thing is that we can actually use ultrasound to help diagnose different eye things. So especially in the case of a retinal detachment, which is more so, people will describe kind of a curtain of blackness covering their vision. It'll either all happen at once, or they'll have like a portion of their vision that is just a sharp demarcation that they can't see out of, or it'll slowly be a curtain coming down until they can't see anything at all. And with an ultrasound, using gel on a closed eye, you can actually see the retina flapping in the posterior compartment, which is another eye emergency, but it's kind of interesting that we can use ultrasound to see diagnoses in the back of the eye.
Now we can see the whole retina without dilating the pupil.
You're looking in the wrong eye.
We start with a good eye for comparison. Retina looks great.
Now for the bad eye.
Eyes wide open.
How's it look?
Extremely pale, no blood flow.
Digital massage, 10 seconds on, 5 seconds off. Order non-contrast head CT.
That was a very fancy contraption. I think a lot of us would love to have something like that in the emergency department. I don't know that it would work as easily as they showed, but they very quickly said the retina looks pale, no blood flow, which would support their first differential diagnosis of a central retinal artery occlusion. And then they mentioned that they can do digital massage on the eye to try and dislodge the clot that is occluding that central retinal artery to try and restore vision. I know that the data is kind of hit or miss on whether this works, but it's kind of like the only tool that we have in our arsenal to help with this condition.
Dr. Hashimi, can I present?
Yes.
32-year-old deaf woman with myofascial headache, ibuprofen caused gastritis, and epigastric pain, and she vasovagaled. But now pain-free after Mylanta and a trigger point injection.
Excellent. That can take care of the pain for several months.
Yeah, and it shouldn't recur if she keeps her screen at eye level. There was a delay in getting an ASL interpreter, and I almost gave up and ordered an unnecessary brain and abdominal CT.
Good thing you didn't.
That felt like maybe a little bit of anchoring. I know I keep harping on this whole encounter, but I think that the history was very good once we had the appropriate interpreter in the room. But it feels like we just anchored on, we have a tension headache because of positions, and then gastritis because of ibuprofen use. There can be a whole lot of different things that cause both of these conditions, and it seems like we just, anchored on the first thing and treated it, and now we can wash our hands and step away. And I feel like the presentation to Dr. Al-Hashimi was kind of, hey, I figured it out, I fixed it, she can go home. But we didn't really talk about what the full differential was or alternative diagnoses that should be considered before we send people home. And this can kind of happen as we go through residency. As a first year or even as a med student, you're kind of expected to, give a full thought out presentation, have a differential diagnosis with like at least 5 differentials on it, and then kind of talk through why it's not certain things and what your plan is to treat or diagnose definitively. And as you kind of move through the ranks and get more confident, but also just more experience, you're kind of expected to do less of all of that because you have those skills. And in this case, I think that we may have been a little too lenient on how much of the history was given, how much of a differential was provided, and kind of just went with it. I hope that she ends up being okay, but I just like this whole interaction, the last 3-4 episodes has been really irking me.
So it could be bipolar or schizophrenia.
Those are the 2 most likely possibilities.
How do they know which it is?
Based on response to medicine, but also with therapy and observation on a ward. They'll monitor his mood and interactions with others.
Is there a blood test or a brain scan that'll tell us for sure?
Unfortunately not.
When properly medicated, people with bipolar disorder can have successful careers.
So we hope for bipolar.
You could hope for your son's happiness.
With early treatment, 20% of people with schizophrenia have a complete recovery.
So 80% don't.
This is a new version of Jackson.
How old was your daughter?
20. Studying architecture at Georgetown. Schizophrenia.
I'm sorry.
Oh, she's good. Living at home, working as a cashier at Giant Eagle. Employee of the month. Lee still has struggles. But there's also laughter and love.
I think that it's great that these parents were amenable to sitting down and having a conversation with this. I believe she said she's a social worker, but specifically for mental health crisis and families dealing with that. And obviously the patient is in a very traumatic situation and trying to understand what is going on completely, but the family is just as much, surprised with this and trying to figure out what's going on and how to move forward with life. And I think it's great that they highlighted kind of the pros of getting treatment. But I think that it also is important to kind of air out the cons of not getting treatment and what can happen. And a lot of people with mental health illness end up taking their own lives, and not getting treatment only makes that a higher likelihood. And not to say that they should use this as like a scare tactic, but I think laying out all of the options and the pros and cons of getting treatment versus not getting treatment is really important in these situations. And there's obviously a time to do this. I don't know that this is that time, but should be mentioned at some point.
Okay, the next step is we're going to take this tube and pass it through your nose, stopping at the back of your tongue. Best not to talk for that. Oh.
Tube soaking in warm water to make it more flexible.
Do you want to try it?
What day and time is it?
4th of July, 2:31 p.m.
When is my tube coming out?
Yeah, we have to put it in first.
I know, just practicing.
Sounds like you're an expert already.
Before I can't talk, I just want to say thank you for everything.
You're very welcome.
Here we go.
Slightly interesting that they were going in with the tube first. It looked like they were going to send that through the nose and then possibly use that as a guide for the scope. But typically we have a flexible laryngoscope or endoscope that is long enough that you can actually load the tube onto it first, and then you have enough length of the scope out of the tube to go into the nose, down into the throat, through the vocal cords, and then you push the tube in over the top of it and then pull the scope out. So just a little variance in practice there, but interesting to see how they'll finish it later.
We have a decision to make. Studies have shown that some vision can be restored with a clot-busting medication.
So get it.
But there are possible risks. For eye stroke, only 17% get better without any treatment.
Only 17%?
Yes, but with the medicine, another 20% can improve. But there can be complications. 2% of patients who receive the medication get worse, and 1% have severe disability or death.
Honey, this one has to be your call.
No, it's our call. What would you do without me?
Figure out how to get by. And I'd probably cry for 2 years solid.
2 years, that's all. I want the medication.
Okay.
I think that was a great highlight of an informed consent where the doctor presented both options of giving this thrombolytic medication versus not, and what the risks and benefits are of both options, as well as how likely it is to work. And I think in the emergency department, we can be very quick to make suggestions and just assume that the patient is going to do or want whatever we are suggesting. But it's always important to have these discussions and make sure that patients understand the risks of even very generic procedures and medications, interventions that we do all the time. They all come with risks, and it's important that patients understand what those are and are able to make their own decisions on whether they want to proceed with whatever those interventions are.
Tubes at 14 centimeters just above the airway.
Okay, Howard, I'm going to start. If you want me to stop, you just put your hand up, okay? Blue mark tells me I'm in the tube.
Looks like you cleared it.
If he inhales, we should see cords.
Okay, deep breath for me, Howard.
Wow. Beautiful.
Cords are sensitive, so we spray lidocaine in the scope.
Okay. 1 cc going in now.
And we'll just give that a second to work.
Hey, how you doing, Howard?
Once the tube's in, you'll have to breathe through your nose.
Okay, Howard, hold still. I am now going in past your vocal cords until we see the carina. Ogilvy.
There. Right and left mainstem.
And the tube slides in.
And the scope comes out.
Great.
Okay, inflate the balloon. Deep breath through your nose.
Amazing.
You good?
Great in tidal waveform.
Does he need a vent?
He's breathing on his own, but a little CPAP wouldn't hurt.
Starting at 5, titrate to 10.
Okay, that went really well, Howard. Now we're gonna check your weight.
So as I anticipated, they just used the tube as a guide for the scope to go in, and then they got the scope through the cords, advanced the tube over it, and finished the intubation there. They mentioned the carina. That is the spot where the trachea breaks into right and left mainstem bronchus that goes to each lung, and that's kind of our typical landmark for where we are shooting to have the tube. We want it to be between 3 and 5 centimeters from the carina, but you want it past the larynx and not past the carina, because then you end up mainstemming one of the lungs, and then the other lung doesn't get to be ventilated.
Best not to toxicate, okay? Just chill.
No, I bit off half my tongue.
What? She said I bit off half my tongue.
You can understand that?
Oh, you should hear her when she's had 2 pictures of margaritas fucked up and slurring.
I know I saw
Princess, what's open? South 15's clean. Deep tongue laceration.
I can jump on this. Robbie and Alice Shamir are both with critical patients. Hello. I'm Dr. Langdon. I'll be supervising your care.
Jesus, CK, your doctor's fucking hot.
So, how exactly did this happen?
We were in between pubs taking a selfie.
Very nice. Until she jerks her head up.
Ooh.
Ouch.
Okay, topical epi did the trick. No more bleeding.
Sweet, I can go home now?
I don't think so. It looks like the Grand Canyon across the back of your tongue.
We need to put in some stitches.
I don't want stitches.
Listen to the doctor.
Don't tell me what to do. This is all your fault.
No, it's not.
Yes, it is.
Princess? Princess, hey, why don't you show Q where she can wait while we patch up her friend?
Of course. Okay, this is a numbing shot for the tip. The tip? That's not where I bit it.
One step at a time.
Anytime that there are bodily fluids, but especially blood, mouth, I'm wearing full facial protection. You don't want that patient to all of a sudden spit, cough, sneeze, anything, and have blood flying into your face and all of your open orifices. In this case, we have a patient who just mentioned that she does not want stitches in her tongue, and this is where this whole medical decision making and capacity to make decisions comes into play, and it seems as though this patient may be intoxicated, which kind of takes out their ability to make some of those decisions.
You're gonna do what?
In order to fix your tongue, we need to move it forward to access the laceration. You're just gonna feel some pulling, okay?
I guess so.
Go for it.
What size suture is that?
Oh, silk, the biggest one we got.
As soon as I cut the needle, you're on traction, Joy. Oh, that is pretty deep.
And now we can numb up the cut. It's best to start with...
Proximal side first so she doesn't feel the distal injection.
Give it 10 minutes. I'll be back for the repair.
It's obvious that Santos feels a certain type of way about Langdon, and it is now affecting patient care again. But when it comes to the observation or supervision of procedures, I don't know if it's different from state to state, but I believe that per the ACGME, or the governing body of residency programs, an attending is supposed to at least supervise the most critical part of each procedure that is being done. So I know that Langdon is going to be coming back for this repair, but I feel like the attending should probably be there for some part of this procedure. Even when residents get to be in their third year and are very competent at all of these procedures, we are still supervised by one of our attending docs during some aspect of the procedure.
Where are you going?
Blisters in North 3.
That's where I'm going.
Did you sign up for the patient?
I pulled the chart from the rack.
You're supposed to sign up on the dry erase board.
You're supposed to have a clipboard for the patient.
I thought the nurse had that.
Hi, I'm student Dr. Ogilvy, and this is, wow, that is some rash.
Yeah, tell me about it.
Student Dr. Javadi, when did this start?
Last night.
And have you been on any hikes recently around poison ivy?
Nope, haven't left the house.
What about new medications? Lotions, soaps, detergents even?
I don't take medicine, nothing new with all that other stuff.
And where did this start?
Everywhere, all at once, just a lot of pain, really itchy. What is it?
Not sure yet. Be back in a second.
You...
What are you thinking?
I have no idea.
Agreed.
Rashes can be one of the more difficult things to diagnose in the emergency department. I would say that there are a few that are emergent that we need to get on top of very quickly, or it could be a risk to the patient's life. But there are a lot of rashes that are more benign. And I think one of the more difficult conversations that I often have with patients is that we in the emergency department are trying to rule out things that are a risk to the person's life or limbs, things that are going to hurt them or kill them very quickly. And it's not our job in the emergency department to diagnose things. Now, in this case, I would be very concerned about this guy. But oftentimes, we don't have the answer for exactly what something is or what's causing it, but we do know that it's not going to seriously maim you in any way and can send you home to have outpatient follow-up. I don't think that this guy is going to have that, but that is one of the more difficult kind of conversations that we have to have.
So sub-Q starts deep. You want to bury the knot.
Yeah, I've done these before.
Joy, how do we cut the ends?
Short, slide to the knot, turn 45 degrees.
Excellent.
Dr. Langdon, we have a case.
It'll have to wait.
It could be urgent.
Find Robbie or Alishemi.
This girl is wasted. Drunk as a skunk.
Should we check a blood alcohol level?
No, it won't change what we do. She can go home when she has a steady gait.
I already sent one off. Joy, do you want to guess her blood alcohol?
Why would I want to do that?
I don't know, because it's fun.
So right there was, I feel like I've talked about that previously, a poor use of resources and practice of medicine. As Langdon said, knowing her blood alcohol level wouldn't change their management. And this happens quite frequently where we have EMS bring in a patient who is intoxicated, and it is very evident that they are intoxicated based on their presentation. And we do a basic exam, get vitals, check a blood sugar to make sure that it's not hypoglycemia causing their presentation. And depending on what happened, whether they had a fall or things, we will do further management. But if somebody comes in and they are solely intoxicated, we don't care what the number is. All we care is that they're able to walk and be clinically sober when we discharge them. And knowing the number doesn't change that. And so in this case, especially where the alcohol doesn't change the sutures that she's going to get, she didn't walk in, she was wheelchaired in, but I'm assuming that was walking and able to talk prior to getting this procedure done. So knowing her alcohol level really won't change anything and was not necessary to draw.
You know, I've been thinking about applying for a fellowship.
I thought you had a job lined up in New Jersey.
I did, to be close to my mom, but she sold our house to travel the world with her new boyfriend. So what's the point of New Jersey?
Yeah, good question. Which fellowship?
I've narrowed it down to ultrasound, toxicology, and sports medicine.
Those are very disparate fields leading to very different careers.
I know, I'm a little undecided.
Do you have research experience?
I was a part of a study on racial disparities in healthcare until the White House cut the funding last year.
Yeah, you are not alone. Have you considered a geriatrics fellowship?
I have not.
I've seen your skills with the elderly, and there are a lot of openings. It might be your best shot. Think about it.
I think something that a lot of people don't realize about emergency medicine is that it is a very broad field, and when we are in the department, we take care of everyone from a pregnant mother, neonate, all the way to the end stages of life and everything in between. But there are a ton of different subspecialties that you can do fellowships for that range from usually 1 to 2 years. And they mentioned a bunch of them there. There are also opportunities to do emergency medical services, palliative care, education, and a ton of others as well. And usually you would do those if you want to, subspecialize obviously, but especially if you plan to work in a academic setting and want to teach down the road, having some sort of subspecialty expertise can position you well for those jobs and give you, a subject of expertise to teach when you have those roles.
Dr. Robbie, we picked up a patient together.
Teamwork.
It's a concerning bullous rash.
We might need a biopsy for pemphigus vulgaris.
It's phytophotodermatitis. What? I asked. He was making 3 gallons of margaritas for a party, squeezing fresh slimes out in the sun.
Let's go take a peek.
I don't need to see it again.
There's the pathologist coming in with the clutch skin diagnosis. History is very important, but I don't think I would have came up with that.
What's up?
12 patients need med refills.
Shouldn't they see their doctors? The Medicaid cuts, we are their doctor.
No, I can't e-prescribe to their pharmacies.
Looking at your pen. Go old school.
Dana, on what?
Lord, you got the security pads?
Sure do. Just need a patient sticker.
Any other questions?
Yeah. What would have happened if you weren't here today?
That is another patient complaint that we get a lot in the ER. We are sheltered as residents in that we don't spend any time in triage, at least yet. We are kind of talking about transitions to potentially doing that, but oftentimes we have patients that don't have access to a primary care doctor or don't have one, and they are on medications and they take them as prescribed. They just don't have someone that prescribes them for them. So they come into the emergency department asking for a medication refill, and oftentimes during the triage process, one of the providers, whether it's a PA, a nurse practitioner, or a physician, will do that prescription for them. They will also make a referral to a primary care provider so that they can try to get established and have that ongoing care taken care of. But some of these patients just are not able to get to those primary care providers and have that access to care, and the emergency department becomes their form of primary care.
No, there is enough paper.
How are we going to get through this mess?
I was about to ask you.
Ask the pharmacist. You can't leave the PDS. Nothing's getting done here.
I think that scene was just trying to show how chaotic the department can become, and it literally looked like a zoo right there. I think one thing that is quite different in an actual emergency department is that it's actually eerily quiet during most times. A lot of patient care happens in silence, and there is communication had between doctors, nurses, techs, pharmacists, but it never looks like that. And I can't say that I've ever been in the position of needing to do all of my things by hand and oral orders, but I've never seen an emergency department looking that much in chaos. Well, that concludes another episode. There was a lot going on. We were back and forth between a ton of different patient cases. I would love any feedback if there's anything that you noticed that I could do better in these episodes, but I look forward to seeing you all next week in episode 10. We'll catch you in the next one.